Welcome back to the Thinking Mind podcast. My name's Alex. I'm a consultant psychiatrist. Body dysmorphic disorder is a psychological condition defined by an overwhelming preoccupation with a perceived flaw in one's physical appearance. It affects up to 2.4% of people. With me to discuss BDD today is psychotherapist Arie Winograd. Arie has spent the vast majority of his 25-year therapy career treating clients with body dysmorphic disorder. He founded and was the director of the Los Angeles BDD and Body Image Clinic. He is the author of Face to Face with Body Dysmorphic Disorder, Psychotherapy and Clinical Insights. Currently, he works with BDD clients in his private practice. Today, we talk all about BDD, some of the causal factors, the difference between BDD and OCD, how a mental health professional can go about treating BDD, and again, importantly, how that's different with OCD, some definite do's and don'ts when it comes to treating BDD, and much more. This is the Thinking Mind podcast, a podcast all about psychology, psychotherapy, psychiatry, and related topics. If you like it, do share it with a friend, give us a rating, follow or subscribe wherever you listen. That will help new people to find us. Also, if you've heard a lot about psychotherapy on this podcast and you think maybe that's something you want to try for yourself, you can email me at alexcurmitherapy@gmail.com. I'm offering one-on-one psychotherapy sessions, both online and in person in the South London area. Thank you for listening, and now here's today's conversation with Arie Winograd. Arie, thanks so much for joining me.
Thank you for having me, Alex.
Today we're going to talk about all things body dysmorphic disorder, BDD, and hopefully clear up a lot of misconceptions people may have about it or related phenomena. Obviously, as I mentioned in the introduction, you're an expert on this condition. You have a lot of experience in managing this. Can you give us just an overview? What is body dysmorphic disorder? What defines body dysmorphic disorder?
Body dysmorphic disorder, we can also refer to it as BDD, is a disorder where people that look normal to the rest of us, to them they appear misshapen, deformed, ugly, where the rest of us can't see that. That is their experience of themselves when they see themselves. BDD is absolutely not vanity. It's the antithesis of vanity. These individuals, again, they look normal to the rest of us, but they don't see themselves this way. BDD is also referred to as the disorder of imagined ugliness. And people with BDD really see themselves that way, as ugly, deformed, misshapen, or it could be a specific area of their appearance that they're hyper-focused on as well.
Do we have any idea what causes, or maybe what collection of factors causes BDD to come about in someone? What makes it more likely? What increases the risk?
So I'm speaking from my experience doing this almost my entire career. There's many etiologies. So of course there's always some neurobiological links that make people more susceptible. Also, childhood trauma, the family system, years of repetitive behaviors, trauma such as bullying, but there can be all sorts of different sorts of trauma, and not always what did happen, but what didn't happen. So BDD, the etiology is pretty much this planetary lineup of a variety of different things that happened or didn't happen, which manifest in what we call body dysmorphic disorder versus ending up as another disorder. So again, there's definitely neurobiological underpinnings, definitely the family system, years of repetitive behaviors we call compulsions, as well as childhood traumas, what did and didn't happen.
What do we know about the neurobiology? Have there been any studies in terms of neuroimaging or what could be going on at the brain level in someone with BDD?
Although that's not my expertise, the research shows many things, including people with BDD have deficits in visual processing. which means that they hyper focus on aspects of their face while missing the bigger picture of their appearance. Most people with BDD, in my experience, vast majority, I would say 95+% of my clients, the body area that they are concerned about is from the neck up, something to do with the face or head. Now, that doesn't mean people with BDD don't have preoccupations with body areas below their neck. However, primarily, most people with BDD is from the neck up. Below the neck, BDD does exist. However, since we wear clothes below the neck, it's easier to hide body parts that are deemed defective. So again, that doesn't mean BDD can't exist anywhere on the body. It just seems that the vast majority of people with BDD, their preoccupations are from the neck up. It could be nose, skin, hair, jawline, teeth, lips, eyes, shape of their head, hair, or any combination thereof. Sometimes people with BDD hyperfocus and they just get stuck on one body part. Sometimes there's a first or a secondary or tertiary body part. And often with people with BDD, it moves around to different body parts. For instance, the person could be preoccupied with their nose, but not as preoccupied, but still preoccupied with their hair, a little bit preoccupied with their facial skin, etc. And then it can shift around to different areas where another area might become the primary preoccupation, and one that was a primary preoccupation previously can decrease.
Something really important that you mentioned that I'd really like to underscore, and that is the difference between a focused spotlight kind of attention and more of a bigger picture kind of attention where we try to take in everything all at once. So you're saying that individuals with BDD, they might tend to hyper focus on one particular body part, such as their nose or the space between their eyes, say, or something like that. And do you think it is that hyper focus which then gives them this distorted image of themselves?
So what you're saying, it's been shown in multiple studies that people with BDD do have deficits in visual processing. And how I understand it means, yes, they hyper focus on an area of their body. So where someone without BDD or without a body image disorder, when they look at themselves, they see the whole picture. People with BDD, when they look at themselves, they miss the whole picture and hyper focus on details, and their brain gets stuck on those details.
I wonder if you've ever come across a book called The Master and His Emissary by Ian McGilchrist. So he's a psychiatrist and he's studied the brain extensively. He's looked at a lot of research. He wrote this book called The Master and His Emissary about the difference between the left and the right hemisphere in the brain, the difference of their functions. And he felt that the left hemisphere is very much more about hyperfocus. The right hemisphere is very much more about taking the bigger picture. And he has a really interesting thesis that people run into problems in all sorts of different ways, aside from BDD, as a result of hyper-focusing on one particular detail and not taking into account the bigger picture. He thinks that's the root of a lot of cultural problems we have, problems that we have sort of with overuse of technology, problems with the way that we impact the environment. Is that, have you ever come across that book?
I'm not familiar with it. I would like the information from you later on. It sounds fascinating.
Yeah, it's very interesting because it just brings home this point that there's the way we attend to things influences our relationship with those things, and that could be our body parts, as in BDD, but then in so many other factors. But getting back to BDD, what does the life of someone with BDD look like?
It's a great question, Alex. So it exists on a continuum, right? Like any quote unquote disorder. There's extreme examples, there's mild examples, and everything in between. So I definitely conceptualize it on a continuum. The vast majority of people that I work with are moderate to extreme levels of BDD. I don't see many mild cases of BDD, and I think there's multiple reasons for that. But let me give you an example of someone who has severe BDD, not quite crippling, but severe BDD. So they might be able to hold a job. They probably can support themselves. They may or likely maybe not have a intimate relationship. And they experience themselves as a body part or parts that they believe are just profoundly, deeply unattractive, and there's massive shame there. So someone who's functioning with BDD, when they're out in public, well, A, they don't feel comfortable, but no one else sees anything wrong with them, and other people don't even experience or think about there's anything wrong with them. But when they're out in public, they believe everybody's looking at said deformed body area. So with someone with severe BDD, not extreme, but severe, let's say they're able to hold down a job, they can support themselves, they'll have some friends, but their life is really limited. They do not socialize frequently because A, they don't want to be seen. B, they think if they are seen, they'll be rejected. So their life becomes really, really, really within a small box. And within that, they're not getting information from the outside world. And so they become more and more hyper-focused on what they perceive as defective. And BDD gets a lot of traction when the individual is isolated from the world because there's no other feedback. I want to comment on perceived. All right. So for us on the outside, we will say that it's a perceived defect because to us, we don't see it. Or if there is something, it's very, very mild. But someone with active, non-treated BDD would not agree with that. To them, it's not a perceived defect. To them, it is a defect. So I'm always careful when I say perceived defect. So those of us on the outside, we see it as perceived. But someone with BDD does not see it that way. They see it as this is a fact.
Yes. There are so many questions I want to ask, but how do you maneuver around that clinically?
When someone reaches out to me looking for treatment for BDD, I would say about 50% don't believe they have BDD per se, but they know they're very stuck. The other 50% that reach out will admit, yeah, I think I have BDD. Now, they're very ashamed of having that disorder, but they have a little more insight. So either way, whether they have insight or minimal insight, I present it as whatever they would like to call it. Obviously, they're reaching out because they're stuck. If they don't want to call it BDD, we don't have to. If they want to call it BDD, we can. But the point is, they're very stuck. So some people with BDD really don't feel they have BDD. That's okay. However, they know something's happening where they're hyper-focused on what they see as defective. They don't see it as BDD. They see it as defective, is keeping them stuck in life. And I'll tell them, well, we'll try to figure out why you're stuck and see if we can get you untangled. So I don't get lost in the diagnosis, if you want to call it BDD or not. The fact is the person is really, really stuck, and that's where I come in, helping the person get untangled from this hyper-focus on what they perceive as a body area that's very defective.
Is it common for you to see clients who think they may have BDD, but when you take an in-depth history, it ends up being something more like obsessive compulsive disorder, OCD, social anxiety? Is that common for you?
When I began my career and I hadn't begun specializing in BDD, I worked with OCD. Late 1990s, that's how my career started. And what led me into working with BDD was, my training was in OCD. And so I was treating a lot of clients with OCD. And back then, everything was thrown under OCD. Hoarding was called OCD. Trichotillomania was called OCD. What we now call body dysmorphic disorder was called OCD body type. But what I started seeing with the clients who had what then was called OCD body type was they didn't respond like other clients with classic OCD. And that led me to get really fascinated with this and go in a different direction with treatment with BDD. So, doing this pretty much a quarter century now, I'm very aware if it's OCD, if it's BDD. I do have clients who have both, but at this point in my career, I can easily discern what it is. And again, since this is my specialty, it's people that reach out to me these days with mostly body image issues. So I kind of have a head start in that way.
And what are the main ways that you distinguish between BDD and OCD?
So I feel that BDD and OCD are very different disorders. The only commonality is obsessions and compulsions. Besides that, they're different disorders and they need to be treated differently as such. OCD is an anxiety disorder, and for years, and still some people today lump BDD under OCD, and I feel that's very problematic. Because if someone, and I hear this a lot, people reaching out to me saying that, well, they went to get treatment for their BDD from an OCD specialist, and this isn't anybody's fault. You just know what you're trained and how you're trained. And the treatment follows the indicated path of OCD treatment. But with very rare examples, they don't get better, right? BDD is a different disorder. So people with BDD have anxiety, but it's not an anxiety disorder. At the root of BDD is the emotion of shame. And something I always say when treating BDD is you can't treat BDD without looking at identity and without looking at interpersonal and intimate relationships. So again, with OCD and BDD, both have obsessions, negative intrusive thoughts that won't go away. Both have compulsions, repetitive behaviors. Besides that, they're different disorders, and the treatment is quite different.
Right, yeah. So, I mean, from my experience, again, I'm not an expert in either condition. If the root of BDD is shame, in my view, from my experience, the root of OCD would be something more like difficulty with uncertainty, a difficulty tolerating uncertainty. Often these manifest in intrusive thoughts about, let's say, morality, what's good or what's bad, about cleanliness or contamination, whatever the intrusive thought is. Then the compulsion is a way of somehow exerting some form of control over the uncertainty that is provoked by the intrusive thoughts. That's kind of what I would say from my experience is kind of at the root of OCD, difficulty with uncertainty and chaos. And I think it's often why, people with OCD have a history of trauma, have a history of feeling like their lives are out of control in some way. And then, as I've discussed with other people on the podcast and people who have had OCD, the compulsions are a way of kind of exerting some level of psychological control over that. But getting back to BDD, someone comes to you and you're going to start treating them, start talking to them. As you've said, you're going to be quite flexible. If they want to call it BDD, that's fine. If they don't, that's fine. What do you think are the mainstays of treatment? How do you approach that client?
Another important question. So again, with BDD, I don't jump right into chasing symptoms. And that can be hard at times because people with BDD are truly tormented. Someone who doesn't have BDD or doesn't work with BDD can't truly understand the depth of torment and suffering that these people have. So when someone comes in, often they're desperate. I can't stop thinking about said body area, and I'm incredibly depressed. I can't leave my house, or if I can't leave my house, I don't want people to see me, etc. So I never jump in to, we must fix. I always find out who this individual is. I get an in-depth background about their history and their family history. And also, building some trust here, right? Most people with BDD, if they've done psychotherapy before, many have before they come to me, that there's people who might have brought the body part up briefly, but it really was never addressed. Or there's a lot of people with BDD who have been in therapy for years, but never brought up the actual diagnosis BDD or brought up a body part because there's so much shame. So a starting point needs, and again, this is no fault of any of the clinicians. If someone doesn't bring, if you're a psychotherapist or a psychologist and a patient doesn't bring to you information, you can't guess something's going on if you don't know. That being said, I always start really with building rapport. And I also, again, you hear this thousands and thousands and thousands of times. People aren't making this up. I tell them I believe everything you're saying because I do. These are people that I hear this all day, every day for years and years. These people don't know each other and they have very similar, if not the same symptoms. They're not making this up. And people with BDD, it's a profoundly lonely disorder, and especially because of the shame. People with BDD usually don't talk about it. If they do, it will be with someone they're very close to. Some don't bring it up at all. So they're left in a world feeling that they're the only person in the world who experiences the world this way. They believe they're deeply ugly, deformed. And also there's people with BDD that may not see themselves as misshapen or ugly as a whole, but a certain body part they're very preoccupied with and believe is wrong. So it's any combination thereof. But they've been, it's a lonely disorder. And they've been often to different clinicians, mental health providers, who respond in certain ways, which is not anybody's fault. However, the person with BDD interprets as, yet again, someone doesn't believe me or they don't understand me. And again, if someone doesn't work with BDD, it's not their fault. How would they know? Since this has been the vast, vast majority of my career, I know how to answer, which is I start by mirroring back their experience. I absolutely believe them. I'm emotionally attuned to them, and I let them become comfortable with me, because many people I start working with have never, ever told anybody. And there's massive shame here. You have to be able to trust someone to share very shameful material. And again, as I said previously, BDD is about shame. It's shame that's been concretized on a body part. So to answer your question, to start out, I always start slow. I start with rapport building. I start with mirroring back their experience, being attuned to their experience, and validating their experience. An example of perhaps what not validating would be is, let's say someone comes and sees a mental health provider and actually shares, I'm disgusted by my facial skin, or I think that my hair is falling out, or my nose looks too crooked, or you name it. And the mental health provider responds, there's nothing wrong with how it looks. Or, if they hear that, they interpret that, the person with BDD interprets that as, yet again, nobody believes me, nobody understands me. And so often they don't go back to that provider, or they just don't talk about it more. When working with people with BDD, you have to validate their experience. You need to be attuned to what they're saying, and you have to mirror it back, because, as I said previously, this is their experience. We don't see it, but this is their experience. So that's where I always start when I begin working with a client.
Yeah, it reminds me of dealing with psychosis, really, in acute psychotic states. And one of the main mistakes psychiatry trainees often make when they're dealing with someone with psychosis or mania, if they have some sort of delusional belief, is to try and get bogged down in the facts or the rationality of whether the delusional belief has any bearing on reality. Like saying someone comes in saying, I think my family is poisoning me, and often a new psychiatry intern will have this back and forth argument about whether it's realistic to believe such a thing. And it just derails everything, because there's no trust, there's no attunement, as you mentioned, there's no therapeutic alliance. So then feeling that sense of emotional validation, how is the patient going to be on board with anything else that clinician prescribes? The kind of the psychiatrist feels that there should be an a priori sense of trust in their abilities and in their authority, And with patients like this, often there just isn't. And we need to do a bit of that work to build that up before we can be persuasive in any meaningful way about an intervention. So I think that's really good to hear, because I'm sure a lot of people who don't have any experience with BDD, that's their first intuition might be, okay, if I just reassure them that their appearance is normal, then everything will be okay. But as you're saying, that doesn't tackle the shame, and it doesn't take into account the emotional component of the transaction between them.
Correct. And I want to clarify something just in case someone with BDD is listening to this podcast right now. You are not psychotic. I just want to clarify that. I know you were talking about something else, Alex, but they may hear that as, am I psychotic? And no, you're not psychotic, and you're absolutely not crazy, but you likely have deficits in visual processing, which means how you perceive an area of your body is not how other people perceive it, but you're definitely not psychotic. What often happens, and this is why I can't emphasize more, do not treat BDD with an OCD treatment blueprint. I can't emphasize that more, because often what happens is people with BDD, if they're being treated as if it's OCD, they jump right into ERP, exposure response prevention. It's great for OCD, absolutely, but BDD is an OCD. If you start any behavioral work too early with most cases of BDD, there's a good chance they will leave therapy, or there's a good chance they'll shut down. It is not OCD, and please do not treat it as OCD. They're different disorders. And that would be treated like OCD model is a prime example of lack of attunement, lack of mirroring, and it's interpreted as invalidation too.
Right, that makes sense. So again, even prescribing a behavioral treatment like exposure and response therapy just doesn't take into account the underlying emotional forces such as shame, etc., which are at the root of the problem.
Correct. Behavioral work comes later, but I never start with a new client. I don't start behavioral work when I begin working with them. It comes later on. There's a time and a place and timing when I do so.
Right, and just so people are aware, ERP, exposure and response prevention, what that might look like for OCD, say, is if someone has a fear that their hands are contaminated, intrusive thoughts about their hands being contaminated. If you do exposure and response prevention, you might get them to purposefully dirty their hands in some way and then prevent them from cleaning them, which sounds terrifying to someone with OCD and someone with those intrusive thoughts. But that's what you do with the idea that the anxiety will peak, but then eventually decrease. And once the patient has the experience of having their anxiety decrease without having to do some sort of compulsion, then they unlearn the compulsion.
I just want to emphasize what you said, that the most important part of ERP, exposure response prevention, for any disorder is the response prevention. Somebody could be doing the quote unquote best exposures ever, but if they don't do response prevention, all response prevention means is not doing a compulsion. If they're doing compulsions after the exposure, they're going to make whatever disorder you're treating worse. So for people that are not experienced with ERP, it's not just the exposure. In fact, the most important part is what you don't do after the exposure, which is you don't do compulsions.
Absolutely. Okay. So with BDD, there's going to be a deeper relational approach. You're going to do a lot of work to establish a rapport, to be emotionally attuned, to validate. Where does it tend to go from there in your experience? Is it very much client-led? What are the signs that someone's kind of able to move to the next step?
So I'm very flexible when treating BDD. BDD is an incredibly inflexible disorder. So if I approached each individual with BDD with a cookie cutter template, already that's rigid. So people with BDD present with very similar symptoms, but how they got to those symptoms is different. And that's why I really need to get to know that individual before I presume I know how I should jump in and treat them, right? Different people need different modalities. There is not one modality used when treating body dysmorphic disorder. In fact, I usually use multiple modalities. And again, it's case by case. So there might be a client that I can jump into behavioral work sooner than others. There may be another client that it takes a year to get to behavioral work. It really depends where they are. I do a lot of work around interpersonal and intimate relationships. I do a lot of work about building identity, and an identity that's not founded in shame. I again, as we're talking about, I do exposure response prevention later on in treatment. I also utilize what's called internal family systems. And for those of you who are not familiar with IFS, internal family systems, that's not family therapy. It has nothing actually to do with the family. So I won't go into detail because this isn't about IFS, this is about BDD. But it is a modality, internal family systems, that I utilize a lot in terms of identity building. So I have to be flexible and shift the course I take depending on what that client needs. Again, there is not one cookie cutter approach to every BDD client.
Is it common for you to have the experience of, say, taking a psychodynamic approach where you help the client make sense of their past and how their previous experiences may have led to a sort of a foundational sense of shame for them?
So I'm going to tread lightly here. It's not uncommon in the world of CBT and ERP that anything within the psychodynamic realm is referred to as talk therapy, and talk therapy shouldn't be used. And again, we're treating BDD, not OCD. So I wouldn't use that term psychodynamic. That's just me. But absolutely, BDD, someone is not born with BDD. BDD comes from somewhere. You could have genetic loading, of course, and have more of a predisposition. But yeah, BDD comes out of the family system. So as we talked about before, there's many etiologies to BDD. One commonality I've seen again and again and again with vast majority of my clients over the years is somehow, some way, BDD always comes out of the family system. That's one commonality. So circling back to your point, whatever we want to call the modality, yeah, we have to look at history. You're not born with BDD. There's factors that go on which make you vulnerable to BDD. So whether you want to use the term psychodynamic or not, if someone's treating BDD and they want to do some psychodynamic therapy, that's totally okay. I would not do it solely. Now, I just describe how I treat BDD clients as inside out and outside in. Outside in is doing behavioral work on the outside. So the clients have done compulsions, repetitive behaviors for years and years and years, which has created an association with a body part and shame and disgust. So we have to get to a part where we're doing some sort of behavioral therapy, usually ERP, in order to unlearn those neural pathways that formed over the years. But you have to do inside-out therapy too. There's a lot of work around the shame and interpersonal connections and identity building, which is inside out. See, because BDD formed from many different directions. So when treating it and getting the person untangled, we have to come from an inside out and outside in. So for any mental health providers who are listening to this, if you have a BDD client, I would recommend not getting stuck on one modality. Often people have their comfort zone, whatever modality that is. I totally understand it. But I wouldn't be wed to one modality. I find that using multiple modalities works the best with people with BDD. Because again, it's a very rigid disorder. And if we say, well, I understand treating via this modality the best, okay, it may or may not work with the client, but you have to be flexible and utilize other modalities and look at it and conceptualize it different.
How directly do you approach helping a client to build more relationships in their life? Say, in my experience, which is limited, clients with BDD may often come and say, listen, I have no friends. My relationships with my family are very poor and disrupted. And obviously that's, as you said earlier, that sense of isolation can make the symptoms worse. How directly do you go about helping someone to like, okay, let's get you some friends, let's see if we can get you into an intimate relationship or improve your relationship with your family? Is that something that's an explicit part of your treatment approach?
It's very important. However, it's how do you approach that? So people with BDD are having a relationship with a body part. And if you're having a relationship with a body part, there's less room to connect with human beings. So the paradox is, if someone with BDD, and some do have friends, it's not like everybody with BDD is totally isolated. It exists on a continuum. But often a person will say, well, I don't have an intimate relationship, or I don't have a lot of friends because I can't be seen or I'll be rejected. And until I get this body part fixed or corrected, I can't, go out and make new friends. So where does it start? So the person with BDD, they're lonely or disconnected from people because of how they look. But BDD, as cruel as BDD is, it's brilliant because it keeps people, it keeps the person with BDD away from people. BDD thrives when the person is isolated. So yes, a big part of what I do is getting the person out there. But, it depends on the severity of the BDD case. If I'm working with someone who hasn't left their house for years, except maybe going to the mailbox at night for nobody can see them, that's going to take a lot more time to get to that point compared to someone who's functioning in the outside world, works, maybe has a relationship, has friends, but it still suffers from BDD. So it really depends on the severity of the client. But ultimately, BDD recovery is about people. And the work I do, regardless of the modality, consists of interacting with people. So it's case by case, depending on who I'm working with, where they are in their recovery, the severity of their symptoms. But one cannot recover from BDD in isolation. It's not possible.
And indeed, one can't be psychologically healthy really without good relationships.
Absolutely. Absolutely. So yes, interacting with people, relationships are an essential part of BDD recovery. How are you going to get emotional mirroring or attunement or love or any sort of human connection if you're isolated in BDD world by yourself and the only information you get is from BDD, which will be sending you propaganda, which is something is so wrong with said body part or body parts. So yes, it takes work, but that is part of the process. The person's recovery has to gradually deal with feeling more comfortable around people. And a lot of people with BDD come from backgrounds where they don't trust. So a lot of that's the inside out work, building trust, starting in psychotherapy, but also since BDD is such a disorder of shame, that's why they don't want to be around people, because they believe that everybody is seeing them like they see themselves. When you think about it, BDD is the ultimate, most severe form of self-judgment. So because that's their paradigm and that's their world, they're assuming everybody else sees them in that body part the same way. When we talk about that, I'll usually hear something that sounds like, well, in fifth grade, somebody on the playground did say I had a big nose, for example. It could be anything. So they take that and they're like, well, someone did see it. And they'll hold on to that, even though this could be 30 some years later, and say, well, someone did see it. All human beings, or most human beings growing up, will get some comments on their appearance, and 98% of the world does not have BDD. But the person with BDD hears a comment, and some are bullied about a body part too. However, they believe that that is now how everybody sees them. So if they go out, they're thinking that other people are judging their nose or whatever said body part like they're judging themselves. Also, people with BDD, untreated BDD, have difficulty making eye contact or being face-to-face with other individuals, because if they look someone in the eyes, they see that person looking at their face. And since that person's looking at their face is what we're supposed to do when we're talking to people, because that's where we connect, But that brings up shame with a person with BDD because they feel the person is seeing on their face, again, what they feel so ashamed about. So they'll break eye contact and look away, which then breaks the connection. And they'll blame, well, this person doesn't seem to be interested in me, or they don't like me, or I didn't connect. But there's behaviors they're doing, like breaking eye contact or changing their posture. So the person they're talking to can't see them at a certain angle. They're doing behaviors which disconnect them from the individual. And then it always goes back to, you see, I can't connect. If I could fix said body part, then I'd be able to have love or connect with people.
So would you bring a client's attention to perhaps some of the behaviors that they're putting out into the world, which may be disrupting their connections with others? Would you bring it to their attention that say, oh, I notice sometimes when we're talking, you might break eye contact, and bring their awareness to how that might be impacting their relationships?
Absolutely. So me as the therapist and the one they're building trust and connection with, right? I'm their first mirroring experience, or maybe healthy mirroring experience. Again, there are people with BDD who are functioning in the world and seem to have a lot of acquaintances or friends. It looks that way. However, they're still suffering from BDD, and they may or may not be connecting with people. So again, it's not always that person who is completely isolated. But yeah, that's definitely my job. I bring all these points to the person's attention because most of the time they don't know they're doing it. And I'm kind of like the front line. Their first experience where they're talking about the most shameful thing in their life, or one of them. And also I observe some things they're doing which likely disconnect them from other people. And so absolutely I bring it to their attention.
Do clients with BDD ever ask for your perception? Do they ever ask, tell me what you think of this, that, or the other, whether it's a body part or some other aspect of themselves?
Yes, frequently they do. And I've learned over the years how to reply and not reply. So if I was to reply, it looks normal to me. They're going to think, well, you're my therapist, you have to say that. Or I'm just lying because I don't want them to feel bad. That's what happens if they ask other people for reassurance. What I tell them is, I absolutely believe this is your perception. This is your perception. You and I may see different things, but if I tell you what I see, you probably aren't going to believe it. But I believe everything you're telling me. Because respond like it looks fine. Or, okay, maybe it's incredibly mild, but nobody would pay attention to it. They're going to interpret it as, you're just saying that because you're my therapist and you can't tell me the truth.
Yeah, that makes sense. And all right, so let's talk a little bit about shame. What's your approach to working with shame as it comes up in the therapy room?
So BDD is concretized shame, whereas a body part has taken on shame. How does it happen? So individuals with BDD have been doing compulsions, repetitive behaviors, for years and years and years and years. At some point in their life, they did a behavior around a body part that they deemed defective, and they got relief. So, of course, if we get relief, the person will go back again and do it again and do it again and do it again. So for years, they've been doing these behaviors we call compulsions around that body part because at one point they got relief, but that relief soon dissipates and they no longer get that relief, but they're chasing that relief. What happens, for instance, if they look at said body part and they experience shame and disgust, they'll do a compulsion, and we can talk about numerous compulsions that people with BDD do. They do a compulsion to try to get relief. Again, they might have received relief years ago, but it's not happening anymore. Every time they do a compulsion, it creates the association between shame and disgust with the body part, makes it even stronger. And then they need to do more and more compulsions over the years to try to get relief. And that just makes the association even stronger, to the point that people with BDD actually feel the body part. I can't tell you how many times someone has said, like, this actually feels wrong, or I feel it tingling, or I feel it drooping, or I feel there's too much air around my hair. They do. And I think what happens there, I can't give you a scientific explanation, is when there's been so many years of that body part being associated with feeling, it's with a negative feeling, it's a two-way street. So yes, when they see said body part, they get that reaction of shame and disgust, but it goes the other way. If they haven't seen the body part, but they're feeling, say, shame or loneliness or a similar emotion, it often takes them directly to that body part. So it's been completely convoluted. People with BDD filter their emotions through the body part. So they're not regulating their emotions internally, they're regulating their emotions through the body part they deem as defective. And years of that just creates that association and makes it so strong. So by the time they get to treatment, I do believe them. They do have all these feelings associated with that body part.
So, I mean, there's one thing I'd like to bring into the conversation which may shed some light on this, and that is an idea I often talk about on the podcast, which is the difference between sensation and perception. So a sensation is the raw sensory data that we take in, which is obviously being filtered, but, raw data that could be like tingling in our nose, or something that we see or smell, or an image that we see. That is the sensation. The perception is the meaning we make out of that sensation. And then between sensation and perception, so many things happen. The sensory data itself can be filtered, it can be processed, and as we've already talked about, data can be processed in different ways. But then, before it becomes a perception, there's also thoughts and emotions which come into play, which really is the explanation for the phenomena you're talking about. That raw data, like some tingling in my nose, can be entangled with all sorts of beliefs, thoughts, emotions, and all of a sudden it can be, I can feel my nose is abnormal, and that is a source of shame for me, which is a perception.
Correct. Yeah, that explains it well. The sensations, the perceptions, and people with BDD do have these exact experiences. And that's why it's hard for them to believe. If someone says to them, it looks fine, well, not only doesn't it look fine to that person, it doesn't feel fine. When someone's having these perceptions, right? When they're having these sensations, they are. And to tell them otherwise would be completely invalidating. With BDD, the identity component is huge, because what's occurred, and this is connected to everything with the shame question you asked earlier, the individuals with BDD, their identity becomes entangled with appearance. Where identity, is usually with people who don't have disruption in their identity development, is diverse, right? It's diversified. Many different parts, none of which are bad, make up that human being and their identity. But with BDD, what's occurred is their appearance, their external aesthetic appearance, becomes the vast majority of their identity. That's how they see the world. That's how they regulate emotions. And the other areas, because there's such a hyper focus on appearance, the other areas of their identity haven't developed. So you have this identity by the time they get in treatment that's very one-sided, one-dimensional, and that's about appearance. So, where does shame come from? Shame comes from childhood trauma. Someone listening to this with BDD might say, well, I didn't have any trauma growing up. I believe them. But it's not always what did happen. It's often what didn't happen. And I can talk about that in a moment. But when there is shame from early childhood, one's identity forms and is forged around shame, which is not the foundation for a healthy identity. So when people come into treatment with BDD, their identities have been founded around a base of shame and their appearance. And the bigger picture work, of course, reduction of symptoms is important. But something I always say, Alex, is BDD treatment begins when the actual BDD symptoms are reduced. That part is the identity building part, because unless a healthy identity is built, it's just a matter of time until BDD symptoms resurface. So shame comes from childhood traumas. And again, someone might say, and I hear this a lot, and it's true, they didn't have trauma. But something I hear with the vast majority of my clients, or something I observe, is it's not always what did happen, it's what did not happen. So what do I mean by that? So we obviously need food, water, shelter to survive. Of course, or we'll perish. Human beings need something else. We need emotional nurture. And that includes emotional mirroring, emotional attunement, emotional validation, touch, and love. Now, if someone doesn't receive that or does not receive sufficient levels of that, how would they know they're missing something? You don't. Because if you didn't receive something, how would you know it exists? And how it often, with someone who did not get it or did not get enough of it, it often presents, usually around teenage years, or older, as this emptiness feeling internally that something is missing, but they can't put their finger on it. So naturally, if you can't put your finger on something, you don't know what's missing, but something feels wrong. It's so easy to go to external things about yourself and what's the outside of us, the aesthetic appearance. So I call it emotional developmental trauma. It's not what did happen, it's what didn't happen. And the irony here is it's the most neglected trauma in any psychotherapy or psychological treatment. Because even the most established, seasoned mental health practitioner, how are they going to know if the person doesn't bring it to the table? How even the best mental health practitioner can't guess what's going on? Because I've worked with this population for so long, and I've seen a commonality with vast majority of people with BDD, I know to ask about that. And again, how do you know what you didn't even know existed? And this is not about fault. It's not about blame. But for instance, if a parent did not receive sufficient emotional nurture themselves, emotional mirroring, emotional validation, they don't know it exists. So how are they going to pass on to their children what they don't even know existed in the first place? So I see a lot of emotional developmental trauma with clients with BDD. Now, clients with BDD do and have, capital T and lowercase d traumas, like someone who may be bullied for a long time, et cetera. That exists too. But not all cases of BDD is there overt trauma. But a very common feature of people with BDD is emotional developmental trauma. And again, shame comes from traumas. So if there's that early trauma in their childhood, that is going to become the base of their identity development. And when one's identity is founded and builds around shame, what occurs is an individual that has to go external to try to feel fundamentally, inherently okay. It could be anything. It could be drugs and alcohol. It could be overachievement. It could be perfectionism, right? It could be, you name it. But in BDD, it's having to fix or find what they feel is so wrong with their external appearance. So their identity gets so entangled with that. Their identity is built around shame. Their identity is built around appearance, and it only builds on itself and becomes more intense. And that's why a greater part of treatment and underlying theme, again, isn't just reducing symptoms. It's starting to build an identity that is not founded on shame. And I see this happen all the time. It takes longer. It's a longer process of therapy, but I see people at any age, who can actually begin forming their own identity, their individual identity that is not founded in shame.
How do you help someone build an identity in the therapy room?
So identity, I get asked questions, well, how do I do this? Or how do I fix this? Or how do I make it? So you don't build identity by fixing or achieving or perfecting. Identity comes from going in and doing things that are uncomfortable, that you would rather avoid. People with BDD, many have avoidant personalities or avoidant personality traits, which kind of go with BDD when you think about it. But you build identity by doing things that are uncomfortable, coming out the other side. So what does this do? When you do something that's uncomfortable that you would rather avoid, what you realize is that you're not made of glass and that you can come out the other side. Also, in this process, you begin learning how to regulate your own emotions inside out rather than outside in. So BDD is an example of regulating your emotions outside in. So if you're feeling shame or loneliness and you go to the body part that you think is defective, that's externally regulating your emotions. That's not internally regulating your emotions. So a big part of identity building is one's ability to regulate their emotions inside out. So we have to start a conversation we'll always be having is about how do we regulate our emotions inside out rather than outside in. Also doing uncomfortable things that, yes, they feel uncomfortable, having to tolerate that feeling and come out the other side. They learn to regulate their feelings, and that builds another layer of self, the capital S self, their individuality. So again, you can't think your way into identity. You can't achieve your way into identity. Anything like that. It has to come from doing things that are uncomfortable. But also, let me add, it entails people. You can't do it in isolation. So yes, when we talk about identity, we're thinking inside out, and that's true. But we need people in our life. People provide mirroring, attunement, and information. So again, it can't happen in a bubble. Our identity building also has to entail connecting with other people.
I think now we're in really interesting territory. I love talking about doing uncomfortable things to grow and develop your personality and your identity. Obviously, this is something that's important for a lot of people, whether or not you have BDD. But when you're working with your clients, how do you identify, what uncomfortable things might be beneficial for them to do? Do you go, for example, through the lens of their desires and their values? Say, I always wanted to do fill in the blank, but I never tried. And you might guide them towards the beginnings of something like that. Or is there another means you would use to identify something that they might go about doing?
So I do a variety of things. Usually, yes, we need to start, we as in the therapy session, to do uncomfortable things. I usually start that conversation and say, we don't want this to have anything to do with the body part starting out. That's just too emotionally loaded.
Because that would just be an exposure.
That would be an exposure too quickly. So starting with something that isn't really body part related, but that's uncomfortable for them. Let me add that, because I said previously, I don't jump into therapy, behavioral therapy. At some point in the session, we have to begin identifying all the compulsions the person does around the body part. Again, compulsions are repetitive behaviors. And with BDD, there are numerous and an infinite number of compulsions. It could be checking reflective surfaces. It could be avoiding reflective surfaces. It could be touching the body area they believe is defective. It could be asking for reassurance. It could be internet research, looking for solutions. It could be going on social media and comparing themselves to other people, or in person, comparing their body part that they think is defective to that of others. It could be studying their shadow. It could be, the list just goes on and on and on and on, right? It could be avoiding certain lightings because they don't want to be seen at a certain angle. It could be changing their posture around people because they don't want someone to see them from a certain angle. It could be camouflage, as in wearing certain things, sunglasses, hats, excessive makeup, you name it, to hide from other people what they think is defective. So the list goes on and on and on and on. We have to identify those, and that can be earlier on in treatment. And I then work with the client to gradually, one at a time, start chipping away at reducing these. When someone stops or reduces a compulsion, it means what? It means they have to feel. They've been doing the compulsion because they've been having these awful feelings around that body part. So this is a very, very, very slow beginning of learning to tolerate and regulate feelings inside out. So with behavioral work, when I do start it, it's with making a list of all the compulsions they do and have them very gradually, depending on the individual and what they can tolerate, reducing the compulsions, because the compulsions are the fuel source to BDD. Every time they do a compulsion, which usually at this point isn't even giving them relief, it strengthens the neurological pathway, the BDD pathway that we'll call the obsession. And I have to explain to them, and they get to understand that when they do this behavior that feels so right, it's actually harmful. Now, this may sound a little dramatic, but I'm using the term these days with compulsions as self-harm, and I'll explain why. So if someone smokes cigarettes, but they don't have the knowledge that cigarettes cause cancer and can kill them, that's not self-harm. If they get the information that cigarettes can kill them and they continue to use cigarettes, that's self-harm. Now, again, without trying to sound over dramatic here, BDD compulsions will not kill anyone. However, it's the fuel that reinforces BDD. And I make the point that I understand before you were trying to get relief because you're suffering. But you have to understand, this isn't theory. This has been proven in so many PET brain scans, MRI brain scans. Compulsions reinforce the strength of BDD and make it worse. So we gradually have to reduce the compulsions, meaning you have to feel. And I explain, these days I'm calling it, actually I call it passive self-harm, to get the point across that I know you really want to do it because you're suffering, but you have to understand every time you do it, you're harming yourself by making your BDD worse. So there's this process, it could be weeks, it could be months, depending on the individual, where they gradually reduce their BDD-related compulsions. We need to remove the fuel source. Now, that's the earliest process of them having to learn how to regulate their emotions inside out, which again is an important part of identity building. Once they've reduced the vast majority of their BDD compulsions, and again, I do this slow. Why? If we were to say stop all your compulsions today, it's pulling the rug out from under them. This is how they've survived to tolerate and regulate their feelings. So for those mental health practitioners out there, I want to emphasize you want to do it slowly. Now, when you get to that point that most of their BDD compulsions are reduced, we can actually start exposure and response prevention for BDD. And I could go on for hours about how to do that. I don't know how much you want to talk about it now. I will say the work I do with ERP with BDD clients is not as if I'm treating an OCD client. So yet again, I want to emphasize, if you're working with BDD clients and you get to a point of ERP, do not put an OCD model on it. Also, the part where they're reducing compulsions, the only person on the planet that can do it is them. So it also builds this internal locus, and it also feeds into their identity building. So not only as they reduce compulsions are they not fueling the BDD, but they're learning how to regulate emotions inside out, which is a big part of identity building. And they're realizing that they can tolerate the discomfort, which builds identity. So it's actually important for multiple reasons, the reduction of compulsions.
So some of the early work you'll do is not to do an exposure, but rather just to reduce the compulsions. So that might be the compulsions to compare themselves to others, to look in the mirror or other reflective surfaces, to do internet research. You start to bring down those compulsions. Presumably they start to have to feel those uncomfortable emotions like shame and related emotions. Do you give them specific ways they can use to regulate their emotions, or is it more of a self-directed approach?
I always prefer starting in session with them. We can do some sort of exercise where emotions come up. And again, as I was saying, BDD is a very lonely disorder where these individuals, they can't regulate their emotions and they have a lot of shame, so they're doing it all alone. I point out they're not doing it alone. Let's do this together. Let's work together. I provide for them mirroring, attunement, validation, and I provide guidance on how to have this emotion, because obviously they didn't learn earlier in their life. An important part of this, Alex, is for them to not judge the emotion. Judging an emotion is basically insinuating that something is wrong with me, thus I'm having this negative emotion. So I tell them the starting point is, we're going to have this emotion. Do not judge it. Human beings have all these emotions. Makes you human. When you judge it, you're pretty much saying, I'm feeling this uncomfortable feeling because something's wrong with me. Because at the base of BDD was shame. And what is shame? Inherent feelings of being defective. So when I'm actually working with them to tolerate feelings in session, it's let's not judge the feeling and let's stay curious about the feeling. So that pulls from both DBT and internal family systems. That's just what I didn't per se pull it from either, but there is that overlap. And what they see, and I explain too, is every time they do a compulsion, it short circuits their brain from realizing they can tolerate the emotion. So when they do a compulsion, they're doing it because they're trying to get short-term relief from an uncomfortable emotion. What I explain is, though, every time they do that, not only do they reinforce the BDD, but it actually perpetuate that uncomfortable feeling to go on and on and on. If you don't judge the feeling, you stay curious and you tolerate it now. Yes, it's uncomfortable, but you're suffering, quote unquote, suffering in the short term for long-term sustainability. Compared to what you were doing before, short-term attempting to get relief, but suffering in the long run. And I do it with them because, well, somebody has to model it for them. So they can actually learn, wait, the feeling comes, and then I'll check in 10 minutes later and they'll have another feeling. And I'll point out to them, well, you were feeling disgust about yourself or disappointment 10 minutes ago. I just want to point out, notice it passed and a new feeling's here. And if this has never been modeled for the person or mirrored, they don't know. And this could be any disorder on the planet, not just BDD, but it's also mirroring for them how to regulate their own emotions. And again, is a big part of building one's identity and regulating emotions inside out, which is antithetical to compulsions, which is trying to regulate emotions outside in.
And then once the compulsions mostly are gone, then it's time to start working on an exposure potentially. And then what do exposures look like?
Okay. What I emphasize to any mental health practitioner out there who's new to treating BDD, do not start any work with BDD individuals with exposure response prevention or anything behavioral right away. It's not OCD. Too soon, there's a good chance the client will bolt from treatment, or they'll shut down, or they'll dysregulate. You're not going to do that at the beginning. In fact, use judgment when you're going to start identifying BDD compulsions and reduce those very slowly. So this could be 2 months down the road, 3, 4, 5 months when we start exposure response prevention. It really depends on where the client is. And they have full control when they want to start. It's up to them, not up to me. So what might a BDD exposure look like? Well, let's say, for instance, there's just infinite examples. Let's say somebody wears makeup. They can't leave their house. They can't be seen without makeup. Let's say it's a lot of makeup. I understand that's protection. I understand. There's no way I would say, take all the makeup off at once. What I might suggest, and again, I'll leave this up to their control, what if you were to do all your makeup, except maybe not do this little part that you consider not that important, and we do a session? I always like doing the ERP first with them. They can trust me. It's a safe space. It's the therapy space. So just an example might be that, okay, then they come to the next session with all their normal makeup, but one little area which they usually cover, they don't. And they learn to tolerate that in session. And let's say then we do that same thing where maybe get them to a place where they can walk out of their home, right? And maybe pass some people on the sidewalk or what have you. Getting to a place where we start really slowly. And then once they habituate means when their brain becomes comfortable, it's no longer a threat of shame. Then I might say, well, could we take off another layer of makeup or something else? So we gradually do that incrementally, again, under their control, what they're ready for, until we get to a point where they're wearing a lot less makeup and they can be around people. We want to get to a point where makeup becomes optional versus makeup controls if they interact with people. I mean, the list goes on and on. Let's say somebody believes their profile of their nose is crooked. And so anytime they talk to a person, they have to make sure they're face to face. So if they're standing in the checkout line at a grocery store, for example, they will never turn 90 degrees because they don't want that person to see their profile because they perceive their nose profile is so disgusting and they're assuming everybody else does too. So an exposure there will start with me in session, which would be, for example, okay, why don't you, I know you always face me straight on, but would you be ready to do something? For instance, you turn your face maybe 10 or 20% in left or right direction when we talk. And that will bring up discomfort because to them, I'm starting to see their nose at an angle that they interpret as ugly or deformed when I don't get any reaction because I don't see it that way. So then when they start habituating to that, who knows, it could take 10 minutes, it could take 3 therapy sessions. Well, we'll go a little more. We'll go 20 or 40% and so on and so forth. So with me, they get comfortable me seeing their profile of the nose. Or the makeup example, the person becomes comfortable with me seeing them with no makeup. So starting with the mental health provider because it's a safe space, but eventually gradually working it into the real world because you got to remember, all these compulsions have been built as protection against shame. The protection against shame. I don't want someone to see said body part because they'll think about it how I think about it, which is it's so shameful and misshapen, and or they'll reject me. I refer to rejection as the capital R word. People with BDD, their ultimate fear is rejection. It's not abandonment, as we see in borderline personality disorder. In BDD, it's rejection. Because to them, a rejection or perceived rejection is the ultimate evidence to them that they're inherently defective. And then that goes automatically to, wait, it's that said body part. Because remember, they filter everything, every sensation, every perception, every experience back to the body part. So ultimately, it's ultimate fright and terror about rejection. And so much of the time, it's their perception that they're being rejected. Now, we all know in life we get rejections and no's and make mistakes. That's normal. People with BDD are hypersensitive to rejection. And any sort of rejection or perceived rejection, it will go to, you see, if my body part didn't look this way, I wouldn't be having this experience. So they avoid rejection at all costs, thus the avoidant personality traits. They isolate, and that's where BDD thrives. So it's this really circular, vicious process where that's where I come in, getting them unstuck and out of that cycle and untangled.
And therefore, would you say that the main distinction between those initial compulsions you worked with earlier and the exposures are that the compulsions, they're things that tend to be done more in private, and the exposures involve other people and therefore the possibility of rejection?
Very interesting, important question. I have to emphasize, do not do mirror exposures when working with BDD. It's not OCD. If you put someone in the mirror with BDD and said, we're doing exposure so you can get used to the body part that you think looks bad, it's counterindicated. What you're actually doing is most likely making the BDD worse. For one, you're sending the message, we have to fix the body part and do therapy around the body part because that's the problem. Guess what? You're already colluding with BDD. You're already saying, said body part's the problem, so we have to go fix it. Two, most likely they will be doing a compulsion. So not only are you sending the message, the body part's the problem, you actually are giving them an opportunity where they will do a compulsion, especially if they're reflective surface checkers. So this is not OCD. Do not do mirror exposures with people with BDD. Most of the exposures I recommend with my BDD clients is that it has to do with people. Because again, remember, BDD recovery is about people. To the person with BDD, it's, especially if they start working with me, they'll say, well, will you make me like how I look. And I tell them, you will know you're recovering from BDD when you're not asking me that question. So recovery looks like getting to a point where they are interacting with people and they aren't thinking about the body part, or they're not thinking about it a lot, right? There isn't the shame percolating to the surface.
Okay, Arie. I mean, we're almost out of time, but one question I like to ask everyone who's a clinician is, across all the decades that you've worked with people, what do you think is the thing that has fascinated you or surprised you the most about human nature?
Wow. I mean, where do I start with that, Alex? But it's a really good question. Human beings are resilient. People with BDD are resilient. People I work with, when they come into treatment, it's pretty amazing how they have survived all these years. Yeah, they need treatment. They're stuck. Nobody can recover from BDD alone. But it always amazes me, the resilience of human beings. And I see this time and time again, with the stories I hear, with the suffering of the cruelty of BDD. So resilience, and also people can change, people can recover, people can heal. So I think, in short, to answer your question, humans are very resilient, and humans can change and they can heal.
That's a great point. Having dived into this topic a little bit with you today, I feel like I need to do a ton of my own research, and we need to have another conversation in the future. Are there some books that would be really good for people to read to learn more about BDD?
Sure. And if you would like to have me back at another time, I'd be more than happy to do so. I'm going to first do a shameless plug. The book that I published in 2016 is called Face to Face with Body Dysmorphic Disorder, Psychotherapy and Clinical Insights. It's written to everybody, to lay persons, to mental health practitioners, etc., and from a clinical perspective, not a research perspective. It comes from a perspective of what I've seen over the years working with clients one-on-one. So again, it's Face to Face with Body Dysmorphic Disorder, Psychotherapy and Clinical Insights. There's the first book that was ever written on BDD. I think it was published in 1996, called The Broken Mirror by Dr. Catherine Phillips. And there's numerous other books out there too.
Wonderful. Where can people find you if they'd like to find out more?
They can go to my website, which is www.bddclinic.com, www.bddclinic.com, and BDD Clinic is one word. They can go to the website, find out more about what I do, the treatment, etc. And if they want to send me a message via an email via the website, definitely feel free to do so.
Perfect. Arie Winograd, thank you so much.
Alex, thank you so much for having me.